So today we're going to be talking about the Missing Middle Project. So for those of you who haven't met me, my name is Steph. I'm a registered psychiatric nurse. I work at BC Children's Hospital, and I'm here with the Missing Middle Project, which is a one-year demonstration with the inpatient psychiatric unit, community mental health teams, so adolescent and adult teams, and the emergency department. And so what we're doing is we have something called a transition and linking to care team that I'm a part of, as well as my new colleague, Sarah, who's on the call today. She's an occupational therapist joining our team. So we are the transition and linking to care team. So we're here to provide education to staff in hopes of improving the experience for people 16 to 24 with mental health and substance use concerns presenting to Richmond Hospital. So there's a couple different components of our team. So we are also creating provincial education, and there is also a research component. So if you're in the emergency department, you may hear about that. But for right now, the purpose of me being here is to support you guys and provide education on this topic. Does anybody have any questions about that? Okay, awesome. So today we're going to be talking about demystifying working with young people. So this is part one of two presentations on this topic. So today we'll do the first half, and at a later date, we'll be scheduling for the second half of the education. This does line up with some of the provincial education we're going to be doing. So part of the curriculum that we're going to be creating will also be talking about this topic in much more detail, and it will be more similar to a course that you would take on Learning Hub and things like that. And next slide. So I just want to acknowledge that Richmond Hospital does operate on quite a numerous amount of Indigenous lands, and just acknowledge that we're grateful to be here today doing education and learning on the unceded territories listed below. Next slide. So the learning objectives for today is I'm going to provide you a little bit more context about the missing middle, kind of how the project came to be, why we're here, why are we even talking about this population. I'm going to go through some of the stages of psychological development and what that means for the population that we're working with. And then the last thing that we're going to go through is understanding adverse life experiences and how that can impact transitions between these psychological developmental stages. Next slide. So just for some context about our project. So this is a chart here to show the disease burden across different ages. So if you see here in the yellow section, from ages 15 to 25, the biggest disease concern for this population is mental health disorders. So between the ages of 15 and 25, 75% of mental health conditions are diagnosed in this age range. So there's quite a few implications with that. And why we're looking at this missing middle age is because we have 75% of people being diagnosed in this age, but they are also split across two different age groups. So between the ages of 15 and 19, we're looking in adolescent and child psychiatry. And from 19 and above, we're looking at adult psychiatry. But can anybody tell me what maybe a difference in that age range would be when we're looking at community services and inpatient services? So what age would be considered adolescent here in this hospital? Does anybody know?
We've had like 17-year-olds.
Yeah. So 17 is considered in the most hospital settings, 17 and under is considered adolescents. For MCFD, does anybody know what the age is for considering the cutoff for MCFD involvement? Yeah, so under 19. And then for some community services, they consider 18 to be the age. So we are looking at a difference in age number. So there's no consistency in what we consider an adult. And so when we're looking at this age range, it is important to note that there are some challenges with regards to getting connected to services, because some places 16 is the age of adulthood, some it's 19, some it's even 24, depending on what the services are. And then we can go to the next slide, Justine. So the Missing Middle Project is an initiative done by BC Children's Hospital and the BC Children's Hospital Foundation. So it's actually based off of a program in Australia called Origin. And they identified this age range, so 16 to 24, as being something called the missing middle. So like I said, there is a challenge with the age range. So are they an adult? Are they a youth? Are they an adolescent? It's covering two different age groups. It's all good. I'm not easily distracted. And then there also is a second challenge, and why we call them the missing middle is that often this population is too unwell for traditional community services. For example, something like Foundry that works with some like anxiety, maybe even depression, but nothing that would be chronic or acute enough to warrant a hospital admission. And so then on the other end of the spectrum, they're not sick enough to utilize services like EPI or the ACT team. So they are in this middle area where they're not sick enough for certain services and too sick for other services. And on top of that, they have the added complexity that their age can be a defining factor of what services they can utilize. So what ends up happening is this population is overrepresented in the emergency department presentations because there is no current services that provides them the care that they are looking for. And also looking at traditional mental health services for this population. We are working in this age range, we are looking at different milestones. So possibly learning how to drive, graduating high school, starting post-secondary education, possibly entering into relationships or romantic relationships. And so there's a lot of milestones and challenges that are happening for this age group. And a lot of services are not taking that into consideration. So if we're looking at an acute program, we're looking at just the psychiatric complexity and the acuity and managing that, but also not, some programs are not able to recognize that there's a lot of other things that are going on for this population. Okay, does anybody have any questions about that so far? Feel free to interrupt and ask questions. I prefer if you ask them right away, just so that you don't forget them. And I'm like I said, I'm not easily distracted. So if you do have any questions, feel free to just ask. So the first thing that we're going to be talking about here is the stages of psychological development. How many people here are nurses? Just by a show of hands. 2, 3, 4. Okay. Did anybody learn about Erickson's stage of psychosocial development in nursing school? Okay, so this will be a little bit of a review, but just as it was the most applicable, I think, to what we're doing with this program. Of course, there's lots of other theories, but Erickson's stages of psychosocial development, the age range that we're going to be looking at today is adolescence as well as young adulthood. So in adolescence, ages 13 to 21, that's sometimes it's flexible 12 to 20, but around that age range, 13 to 21. The goal for this age range is identity versus identity confusion. So as you can imagine, adolescents during this period are often trying to figure out who they are, who they want to be friends with, what they want to do, what they want to look like, maybe sexual orientation, gender identity, all these different things are happening in this age range. So the goal during this developmental stage is for them to solve the identity versus role confusion crisis. So essentially to figure out who they are and what they want. They need to construct their own unique sense of identity, find the social environment that they can belong to. So making friends is a very big part of this age range, and create meaningful relationships with other people. So that's a process that starts in this age range. And so this often during this age range, we will see a lot of trial and error. So trying out new things, figuring out who they want to be friends with, moving around from friend groups, trying out different personalities and different things that they're interested in. So with all the ultimate goal being figuring out who they are. And comparatively in the next stage, which is adulthood, so this is around ages 21 to 39. So the goal during this stage is intimacy versus isolation. So in this stage, we're looking at starting those romantic relationships, making lasting friendships. By this stage, we would hopefully have solved the identity crisis. But at some point in some ages, as you can imagine, a 21-year-old may not still know what they want, right? So that's sometimes can lead into this adult stage. So intimacy in this stage, Erickson describes it as the capacity to be open, vulnerable, empathetic, and welcome to authentic and close connection with others. So essentially creating those important lasting relationships is what we are trying to do during this stage. So when an individual is successful in this stage, they are able to form these committed long-term relationships. If they are not successful in this stage initially, they will struggle to form and do not find significant relationships and may experience isolation. So research has found that risk factors for loneliness can involve social relationships, physical health, mental health, socio-demographic factors, and participation in society. So during this stage, we are trying to prevent isolation because we do know, I think we all recognize that isolation can be a huge factor in mental health and physical health conditions. Right, next slide. So just for just like a group discussion about different ages and the different developmental stages. If you just want to click next, Justine, so it pops up. Can anybody tell me what some differences between adolescents, young adults, and adults that you've noticed in your clinical setting? So young adults, I would say anybody under the age of 25, so 19 to 25, and then adults being 25 to 39. Can anybody think of any differences between these three populations that you've noticed in your clinical settings?
I think from an OT perspective, like I've noticed a lot of young adults here are having, they have a lot of goals related to like getting into school and like finding jobs. And I mean, that is also a thing with older adults as well, or middle-aged adults as well. But I've noticed that like across the board, it's always like, I want to get into school, or like those and even like pre-vocational skills as well. So
yeah,
similarities just in.
I would add on the finish, sorry.
Oh yeah.
With young adults, they mostly have their own like first space down. They're just new to the system. They're trying to cope and lack of ability to cope. Adults are less, we see this more adaptation, more acceptance to them, and more insight into their.
Yeah, that's a good point. Yeah. So usually with the young adolescent, even young adults, we're seeing first presentation of psychosis or even like bipolar diagnosis. And usually when we have an older adult, older quote unquote, somebody over the age of 25, we often do see a systems understanding, right? So they've been through the system, they've had this diagnosis for a period of time, they understand how the system works for the most part, they possibly have some more insight into what's going on with them. Comparatively with the adolescent population, we are often the first point of experience for them for the mental health system. So that can be a big difference. Anything else that you can think of? Yeah.
Yes.
So the way that substances are used, yeah. So there's a lot more exploration with the younger population versus when we see older patients, generally they have kind of a substance of choice, or there's been like a chronic pattern of use. Yeah. Anything else you can think of?
Their families are also.
Yes. Yeah, that's a huge difference. So how many times would you see an adolescent patient with no family involved? It's quite rare. Versus often, even our young adults or older adults, we very rarely see family members. Maybe there's a partner, maybe there's a child, maybe there's a parent, depending on the age range. But I wouldn't say that they're as involved as we see with our adolescent patients. It would be very uncommon for us to see an adolescent patient without some form of legal guardian or adult present. How do you think that that changes the way that we provide care with these populations? And how do you do that in your setting, I guess, in the inpatient unit?
Try to involve families, decisions, like we host a lot of family meetings here, especially with young people.
Yeah.
So everyone is on the same page.
Yeah, exactly. Because if they're going home to their family setting, then it is important for their family members to understand what's going on for them, right? That's great. Yeah. Justine, if you're able just to click next. So this is everything that you guys talked about. So goals. So the goal of a teenager or an adolescent is very different usually than the goal of an older adult. So like Ainsley, right? Yeah, Ainsley said, we're looking at getting a job, going to post-secondary education, maybe learning how to drive, all these different skills versus an older adult. We would assume that they've probably done these things before, or maybe they're starting a new job. That's possible. They could be entering into a new career. But generally the goals are different for these populations. And that goes in hand with milestones. So we would expect that a goal of an adolescent or a milestone would be graduating high school versus an older adult. We would assume that they've already completed high school or they've already transitioned out of the high school timeframe. Life experiences. So life experiences for adolescents, young adults, and adults can vary. They can vary. But they can also be quite similar. How often do we meet teenagers who have the life experience of some people we would consider an older adult, right? That have been on their own for long enough that they do have the same life experiences sometimes as these older populations. So that can make a big difference in how we provide them care because they do have that different life experience. So the severity of mental illness. So if we are looking at something like a first break psychosis, generally the severity is not sometimes is not at the same level as what we would see in an older adult who's had multiple psychotic episodes. Systems experience, so I mentioned that before, is if it's a first break psychosis, they generally haven't probably been to the hospital before. They might not have even seen a doctor if they're 16 years old, or even had the experience of going to an emergency department. So their experience in the system is very different than those who have been here, 20, 30 times for a variety of medical or mental health conditions. And then their knowledge base, right? So we would assume that someone who is the age of 40 probably has a different knowledge base than someone who is 16. And then insight and judgment. So this can really be dependent on what the mental health diagnosis and presentation is. As we know, someone who is in a manic episode may not have that great of insight and judgment, but more so referring to understanding of systems and limitations of the medical system. We would expect someone who's been through the system multiple times would have more insight into what is going on and what the limitations are of the mental health system. Does anybody have any questions about that or any comments? We'll go to the next slide. So the next thing that we're going to talk about is factors that can impact transitions. Next slide. And one more click. Yeah, okay. So in your guys' clinical setting, what are some undesirable behaviors that you see? I see you smiling, so feel free to list them. Anything that is considered undesirable, unwanted behaviors that you see in your clinical setting. Sexually inappropriate behavior, yeah. What else? Suicidal ideation, yeah. Okay, yeah, suicide attempts, self-harm, yeah. Smoking on the patio, okay. Yeah. Contraband, okay. What else? What about their behavior to you as clinicians? What kind of unwanted behaviors do we see other than the sexual behavior? Yeah, so verbal threats, yeah. Confrontational, yeah. What else? Staff splitting, yeah.
Disrespect.
Yeah, disrespect, irritability,
Holding alarms.
pulling alarms, pressing the code white buttons. Yeah. Those are all very specific. Yeah. Anything else you can think of?
Not listening to you.
Yeah, not listening to you. Yeah, okay. Justine, if you want to just click one more time. So yeah, so you guys got a little bit more specific than I did. Keeping in mind, I do this presentation with the emergency department and outpatient as well. So I tried to be generic as possible, but yeah, yelling, hitting, kicking, outbursts, swearing, threatening, inappropriate laughter, like it was saying, I don't know, not answering our questions, not being quote unquote cooperative with nursing care, help seeking and help rejecting behaviors. This is something coming from adolescents we see a lot, but of course we do see this in adults as well. Self-harm and suicidal gestures, suicidal comments, lying or withholding information. So these are some pretty common things that we would see across all these different settings. So community, ER, as well as inpatient unit. Next slide, Justine. And so what are ways that you support patients or clients with these undesirable behaviors? Provide education. Yeah, what kind of education do you provide? Reality feedback, yeah, information about their rights. So your Form 13, what are your rights? How many times has a patient said you're holding me against my will, right? That's true in most settings, right? That you are involuntary, and so we do provide them with their rights. How else do we support them when we have these undesirable behaviors?
Asking questions to see what's motivating the behavior.
Yeah, so asking questions, trying to understand why are we upset now? You've been here for 6 or 8 hours and now you're yelling at me and swearing. What happened in that time frame? Yeah.
Show someone that the care that you're providing isn't conditional based on their behavior.
Yeah. Yeah. So I don't know if anybody in nursing school learned a term unconditional positive regard. Did anybody learn about that? So that understanding that just despite any behaviors that they have, you do always have that unconditional positive like thought towards your patients, because we do have an understanding as clinicians that there's a lot of things that can be driving these behaviors. And always seeing your patients in a positive light, just recognizing that right now they are not their best self. And if you were probably in their situation, you might be acting out as well, right? You might be exhibiting some of these behaviors if you were being held somewhere against your will and you felt that you didn't need to be here. What else do you guys do to support your patients? Even like things that you guys probably do all the time and don't think about, like what are ways that you provide comfort to patients? Pardon? Verbal de-escalation. Yeah. What kind of verbal de-escalation? What do you do for patients? Empathy. Yeah. Ask questions. Provide reassurance. It's going to be okay. We're gonna support you while you're here. What else? Motivational interviewing. Wow. Okay. So motivating them. Yeah. For your patients that have substance use, using that with the motivational interviewing techniques that you've learned, if you've been fortunate enough to get that training. Yes. Yeah. Anything else that you guys do? Yeah. Yeah. Last resort. So least restraint policy. So utilizing the least restraint policy. Justine, if you want to click one more time. So there's lots of things that you guys list, right? So providing empathy, so privacy, giving them space if they're upset. Like, I'll leave you to your room, but I'll come in and check in you in a couple minutes, right? Sitting with them if safe to do so. So these all obviously keeping in mind this is all is all conditional on the fact that you feel safe to be in these situations. Of course, you have a code white policy, and if you are feeling unsafe, do not sit with a patient who's being aggressive towards you. But if able and you are comfortable sitting with them while they vent or they're upset, that's also an option. Providing food and fluids. How many times have you been hangry and you've gotten upset with someone? Keeping in mind, I brought donuts if anybody would like any, right? So everybody responds well to food and fluids. If we're upset and we haven't eaten in a while, we might be a little bit more upset. So providing that option is always great. Comfort items. So depending on the age range or what the needs are, blankets, photos of family, stuffed animals, depending on the age, of course. Low stim environment. I know on a unit like this, what is 25 beds you guys have here? 21 beds. That's a lot of people and a lot of noises all at the same time. So I can appreciate that a low stim environment might not always be conducive on this unit. But wherever we can try to do that, then we do try. Validation. So validating, like, it does suck that you're here today. I'm sorry that you're missing, your family's event and that you have to be here in hospital and you feel like you don't need to be here, right? Distraction. So you guys are fortunate that you have quite a few distractions here. So exercise equipment, TV, going out on the patio, just not bringing your cigarettes, that kind of stuff, right? Family. So this is a plus or minus, right? Sometimes family can be upsetting or distressing to people. So keeping that in mind, that if someone is exhibiting some of these unwanted behaviors and the family is present, maybe removing the family from the situation might be helpful, but also acknowledging that maybe having family present might be helpful for them and might be grounding for them. Letting them vent. How often do patients just want to yell and get it all out and then they're okay after, right? Giving them the space to do that, because we do that, right? That's something that we do. And then coping skills. So these are things that we would have to support. So that comes into the education. So what education are we providing to our patients? Especially if this is a first presentation to hospital. We assume everybody knows what they need to do when they're upset, but that's actually not the case. We do have to teach coping skills. That's part of our job. And so providing that support if we're doing that in the hospital. Yeah. Next slide. Okay, so what I am gonna do is I'm gonna show a video here.
Steph, do you want me to stop sharing?
No,
Or-
you're good. I can actually I can move between it on the screen the way that we're doing it, so you're good.
Okay, and folks on the phone, I guess, or joining in will be able to see.
That's a good question.
If
If you click that,
yeah, let's do some tests.
and then we'll go to the 4-minute mark.
Um,
Yeah. So with the limitation of time, I did have to cut down the video.
Sorry.
But what I will do is the presentation will be sent to Amy and Carmen, and they will send it out to you. So if you're interested to watch the whole 60 minutes, I do find it very valuable. You may have seen this if you went to nursing school, I'm not sure. But we'll just watch 5 minutes of it. So this is factors that can impact transition. So it talks about adverse childhood experiences.
No.
To Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at
Oh, did that pause for you?
Yeah.
Okay. Sorry about that.
Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC. And together, they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed.
So we'll stop the video there.
So
This is it's a
through my
16-minute video. I highly recommend, if you're interested in learning about adverse childhood experiences, the effect on the medical system, like your medical and physical system, is quite interesting. From the age of anything as young as like under the age of 2, there is quite significant implications for that. We'll just go to the next slide, Justine.
Sounds good. And we can share out the link in the slide deck after, just for folks
Yeah.
that are interested.
Yeah, totally. Yeah. So just as I know it was a little bit hard to hear possibly for you guys in the back. So the categories of adverse childhood experiences. So there's 3 different types of abuse: physical, emotional, and sexual abuse, physical or emotional neglect. And then so some different categories of household dysfunction. So a family member with a mental illness. It says here, mother treated violently, any form of domestic violence is in the category. Divorce, an incarcerated relative, and substance abuse. So these are the different categories that we see for adverse childhood experiences. They are in the process of broadening these descriptors because, as you can imagine, there are a lot of other things that can impact childhood experiences other than these 12. So they are in the process of expanding the ACEs study. And then we'll go to the next slide. So an overview of the increased health risks. So we'll go back one, yeah. So the increased health risks. So some of the behaviors that we will see is lack of physical activity, smoking, drug use, alcohol use, missed work, and then the physical and mental health effects of that. So some of the really common ones that we see. So these, of course, increase as Dr. Burke said, they increase in likelihood with every ACE score you get. So if you have 1 ACE score, you are still likely to get all of these things, but every point you go up, you are more likely to get this ACE score, or to develop these conditions. So severe obesity, diabetes, depression, suicide attempts, STIs, heart disease, cancer, stroke, COPD, and broken bones. And so in the video, I'm not sure if you heard, but anyone with an ACE score above 3 is 12 times more likely to have a suicide attempt at least one time in their life. So that's a pretty big implication for our practice when you consider the population that we work with. I don't know that anybody who has ever been admitted to your unit has 0 ACE scores, if you think of those categories that I just listed, right? So, and upwards of seeing anywhere above 7 would be probably more of the baseline and more common. So as you can imagine, there's a lot of other implications for that and effects on our physical health as well as our mental health, if we do have any of these childhood experiences. And so we'll go to the next slide. Okay, and so other than the ones that were listed for the ACE categories, divorce, physical, emotional, sexual abuse, what other factors do you think can impact transitions for young people? So what other life experiences do you think would impact someone's ability to successfully transition between adolescence to young adulthood to adulthood?
Low socioeconomic status, like poverty.
Yep, poverty, yeah.
I think just also currently like the global focus and awareness of everything that's going on, like wars breaking out
Yeah.
daily and
War.
environment, the like climate change and the effects. I think kids are so exposed to that now and they're very anxious about it.
Yeah, that's a huge, yeah. So climate anxiety, that's a huge, huge thing that's happening with our young people right now. What else? The war, climate anxiety.
That move around all the time.
Yeah, lots of movement. Yeah, like depending on what the reason is. Sorry, I have somebody in the chat that just had a comment as well. Neurodiversity and intellectual, physical. Yeah. That, yeah. Anything else? What about any vulnerable populations? Can you think of any populations that we work with that we would classify as vulnerable?
Immigrants, refugees.
Immigrants, refugees. Yeah. What else? Indigenous adolescents and young people. Yes. What else? Yes. Yeah. So our queer community. Yeah. So all of these are factors that can impact transitions. If you just want to click the next one, Justine. Yeah. So a mental health or a physical health diagnosis. So if you're diagnosed with schizophrenia at 16, you better believe that's going to affect your ability to transition, right? When you're in and out of the hospital, it makes it really hard to graduate high school, right? War and everything that we're seeing right now in the Middle East. Those young people are not going to have the same life that we have. I'm very fortunate to have right now in Canada, right? And we may see these people coming to Canada. So when we're working with this population, you can imagine that there's a lot of different things that we're going to need to do and to support them as clinicians. Natural disasters, so fires that have been happening, people that have been misplaced. If you have nowhere to live and you're looking at Maslow's hierarchy, housing is pretty much the baseline at the bottom. If you don't have housing, we can't go up from there. Identifying as in part of the LGBTQ community. So when we look back at the goals of adolescence, so identity versus identity confusion, if you were someone who struggled to come out or didn't have the support or the acknowledgement of your identity, and you waited until you moved out of the home and you're 25 years old, that will impact your transition because now you're starting from somewhere that somebody may have started when they're 16, but you're actually 24. Intergenerational trauma and racism that we see with our Indigenous populations. So I'm like, when we're looking at impacting transitions and we're talking about racism, we're talking about that repeated constant racism that our people of color in our communities face. So having that, and especially when we're looking in places like the US and the effect on the Black population and the repeated racism that they experience in all aspects in every system. If you can imagine, if you experience that every single day, then that does have an effect on your ability to move forward and move like through your transitions in your lifespan. And same with intergenerational trauma with our Indigenous population. This one, caregiver expectation on youth from parents. So this is referring to not you have to do chores and things like that, not that. So it's more around the expectation of putting you into a role that may not be the traditional role of a young person. So if you think of perhaps a 16-year-old that is expected to look after their younger siblings because they live with a single parent, that is not necessarily conducive to moving, that can impact their transitions if they are expected to take on a role that maybe is not the traditional role that you would expect for their age, or even a young person who's expected to look after possibly like a grandparent that lives in the home. So that makes it difficult for you to transition through to your young adulthood if you have expectations put on you that are not expected during your transitional stage. So the forgotten youth when sibling or family member diagnosed with mental health or a physical health concern. So if you are 16 years old and your 18-year-old brother has been diagnosed with bipolar disorder, sometimes what we will see as a younger sibling as almost a quote unquote forgotten sibling, because there is so much other things going on with the older sibling. And so that makes it difficult for you to get the support you need to transition to the next stage of your life. And then age of onset of the mental health concern. So I'm going to talk about that on the next slide. We'll go to the next slide, Justine. Yeah. So why does age of onset matter? So when I say age of onset, I mean age of onset for a mental health diagnosis. So we are referring to some more chronic conditions. So schizophrenia, schizoaffective disorder, major depressive disorder, bipolar disorder. So what happens when we have the age of onset is that what it can do is make someone's chronological age, so the age that they are on their birth certificate, how old they are, it can make it seem different from their developmental age. So if you think of someone who was diagnosed with bipolar disorder at 17 years old, they may not have the same capacity at the age of 24 that you would expect and compare to other 24-year-olds that are sitting in front of you, because they were diagnosed at the age of 17 and were not able to meet those life goals, those milestones that we expect, learning how to drive, learning how to grocery shop, those kind of things. So the age of onset matters because if they are diagnosed at a younger age, they will not have had the same life experiences as someone who was diagnosed at 25. So why does that matter? So when we're looking at prevention, that is one of the hallmarks of programs like the EPI program. So the early psychosis intervention program is looking at prevention. So by putting off a diagnosis until the age of 25, 28, 30, if we can even get there, is that they are able to develop the life skills like living alone, buying groceries, having a financial plan, learning to drive, getting their first job, having friendship groups and interacting with peers. So this gives them an opportunity to develop coping skills and emotional regulation during times of distress. And by having these preventative methods to prevent the onset of a mental health condition until later in life, this actually improves the chance of recovery or remission of a mental health condition. Does anybody have any questions about that? Does that make sense to everyone, that if we can push off a mental health diagnosis until later in life, that we are giving that people the opportunity to learn these skills that will eventually make it more conducive to recovery and treatment, as if they were older and compared to someone who was 16. So often what we will see, for example, I primarily work in an emergency department. So what we'll often see is people that are 30 years old coming in and acting like someone we would say is more similar to an 18-year-old. And when you're looking at the age of diagnosis, sometimes what we actually see is a pause from the age of diagnosis. So they were diagnosed with this disorder at 18 years old, and they haven't moved forward a day since then, even though they're 30 years old now. So that's something that's really important for us as clinicians to take into consideration, especially when we're working with people that are 21, 22, and they're coming across as like a 15 or 16-year-old. So their developmental age is not the same as what their chronological age is. And so we can't expect them to act like a 22-year-old if they have the developmental stage of a 16 or a 17-year-old. So we have to change our expectations of this population. Okay, next slide. So I have a group, kind of more of a group discussion. So a 23-year-old male comes into the emergency department via Section 28. He's handcuffed, he's swearing at the police officers, and he's dismissive towards triage staff. You get initial handover from the primary nurse who lets you know that this patient has a long-standing history of schizophrenia and substance use. He also has an ABB or a purple dot on his chart. So as clinicians, how would you feel initially interacting with this patient? So This is the information you've been given, and maybe you've had the opportunity to look into their chart a little bit and their medical record, but how do you feel as a clinician interacting with this patient? Cautious, yeah. Yeah. Does anybody feel nervous? Worried? Right? So someone, they have a diagnosis of schizophrenia. We don't know if they're psychotic or not right now. We don't really know what's going on, but a little bit worried. Anybody else have any thoughts? How you feel about this? What about, you guys are the nursing students in the back, right? I'm gonna pick on you a little bit. How do you feel as nursing students with this, if you were given this information? How does that make you feel?
Nervous but curious as to what brought on this onset,
Mhm.
some precipitating events.
Yeah. Okay.
I would assume they're already connected to a team in the community.
Yeah, especially with a long-standing diagnosis, we would hope that they're connected to a team. They could be new to the city and maybe not, but yeah, we would hope that that would be the case. Yeah. Okay. Any other feelings? Okay, we'll go to the next slide, Justine. Okay, so if you met this patient in the emergency department and they are in handcuffs and they're swearing at the police officers, maybe resisting the officers a little bit, how do you think you might react to this patient? Yeah, okay. Go in with security. Yeah, what else?
About rapport building. So I'm gonna go in trying to butter them up, make them feel like I'm on their side. I'm not with the police who've apprehended them, the people that they're feeling angry towards.
Yeah.
Great food, water, some options.
Yes, food, water, options, snacks, the best sandwiches in the fridge. Get the cheese ones or the chicken, right? Like that's how you build rapport initially, and separating yourselves. The goal is not to separate ourselves from the police officers, but also to let them know that we have a different goal than the police officers. Their goal is to keep the public safe. Our goal is to support our patients, right? So to let them know that. Yeah. Any other reactions towards this patient? Okay, so we'll go to the next slide. So these are some examples of what we might see if we are nervous about interacting with a patient with this kind of history. So avoiding the patient, maybe not answering the questions. We might we've seen them go into seclusion or have restraints. You may validate them. It really sucks that you're here with the police today. I'm sorry that this happened, right? We might offer them some PRN medication or have security present if we're worried about our safety. Ignoring possibly, just avoiding the behavior. If they're swearing, okay, well, maybe I'll just let them sit on their own for a bit and they can cool down, right? Instructing them to stop the behavior, asking them to return to their room if this is a situation where they do have a room. Entering into a power struggle. How many times have we entered into a power struggle with a patient where we have a different goal than the patient has, and we end up misaligning these goals and we enter into a bit of a struggle? Has that ever happened to anybody? Yes, yeah, it's definitely happened to me a couple times. I have a goal to come in here and do X, Y, and Z, and the patient wants none of it, right? And I want to make sure that I'm getting my documentation in and I'm getting my vital signs. So acknowledging that sometimes we do get into a bit of a power struggle. Sometimes we'll request an involuntary admission if we are concerned about their safety and their behavior. Sometimes we'll withhold options. So I've seen that in the clinical setting where we withhold options because their behavior is inappropriate. Until you can act appropriately, then they're not going to be giving you an iPad or whatever we're offering them. So denying options because of their behavior. So sometimes we do see that. Some of the more positive things that we see is providing that empathy. Like it sounds like you've had a really hard day today, right? Like, what can I do to support you? And then going back with the seclusion and restraints, that's something that sometimes we see with these behaviors. So we'll go to the next slide. Okay, so that is a bit of a teaser for what we will be talking about in the second half of the presentation. So how to manage those undesirable behaviors. So the second part, like I said, we will go into that, but it is just a little bit of a self-reflection of what we do when we work with patients that challenge us, right? So what do we do if we have these unwanted behaviors, and how do we show up for our patients? So some of the things that we've gone over today is the Missing Middle project as a whole. So why I'm here talking to you and doing this education. So our goal here, as a reminder, is to provide the education to staff to work with 16 to 24-year-olds with mental health and substance use concerns, in hopes that by you having a better understanding of this population, that it will improve the patient's experience and their family members. So we went over the developmental stages. So for adolescents, that's identity versus identity confusion. So figuring out who we are and what we want. The second developmental stage for adults was intimacy versus isolation. So building those relationships, romantic or platonic. What behaviors we notice in our department. So those unwanted behaviors and what might be leading and causing those behaviors. So is it the trauma? Is it something else that's going on that we don't fully yet understand? And then adverse childhood experiences. So the review of ACEs, so the impact that trauma in childhood has on our young adult and adult population, and also the physical and mental health side effects of that. And then a reflection of how we show up for patients that are exhibiting unwanted behaviors in our departments. Next slide. Okay, so that is the first half of the presentation. Does anybody have any questions or comments or feedback about that presentation? No questions? Okay. So I will go to the next slide again. If you are able to fill out the post survey, it's really helpful for us, and really good feedback. It's somebody else looks at it, so feel free to put as many comments as you want with regards to the education, because your feedback is really helpful for us to understand what you want from your education. So next time I come in, if this is not the setting or the information that you were hoping to get, then if you let us know, then we can implement that for our next education session. And of course, because this is a demonstration project, the evaluation and understanding of your experience with the education is very helpful for us, so that we're providing education that you guys want, like I said, and using it for our project as a whole as well.
I just have a question, Steph.
Yeah.
I guess if questions kind of bubble up, maybe later in the day or, in the upcoming days, how do folks kind of get a hold of you or kind of get questions, or ask you questions?
Yeah, so if you guys do have questions that pop up, I think, is my banner still posted somewhere with my information? If not, I can send it out with, so Amy and Carmen are gonna send out the PowerPoint slides to all staff. We are in the process of also creating a team site so that you guys can go on and see any of the resources that we've created so far and any other PowerPoint presentations. And if you do want to get a hold of me, you can contact me by email. So stephanie.mcmaster@cw.bc.ca. And I am available by phone as well. And my email is usually the quickest way to contact me if you do have any questions about that. And it will be sent out, like I said, by Amy and Carmen, and my contact information will be available on there. Yeah. Okay. So I think we'll stop the recording, Justine.
Sounds good.
And if anybody, I don't know if anybody's still here